Good morning, everyone. So I'm Simon. I'm one of the senior specialist nurses in Oxford, as Carol says. So thank you very much for Carol and colleagues for inviting me to speak to you today on post-operative pouch care. So just an idea of giving you an insight into and to discuss post-operative nursing care after pouch surgery. So we'll go through IA pouch to start with, and then we'll go on to K pouch. Oops, going the right way. There we go. So there are lots of information, well, a little bit of information, booklets and literature out there. IA has their own available to download from their website. I'm sure they've probably got paper versions here as well. I think St Mark's have some literature as well. We have been redoing our booklet for the last 4 or 5 years. Lots of delays for various logistical reasons out of our control. It's hopefully going to print very, very soon. I said that this time last year, but we're just about getting there. So that will be available with our new booklet soon. The various ones explaining surgery, if you've got a new pouch, dietary stuff and things, and living with a pouch and stuff. So length of admission will vary, but as Richard said, it's around about 5 to 7 days, sometimes a little bit longer. This is for ileoanal pouches to start with. And so general post-operative care is basic nursing care the nurses will do with you on the wards. As Richard said, you do have I shouldn't call it rectal catheter IV because you haven't got a rectum anymore, but pouch catheter. So that was from when I was a student nurse many years ago. Stoma nurses, when pouches were first being done, kept hanging on to the ward nurses. We kept calling it rectal catheters. It can't be a rectal catheter because you've not got a rectum anymore. It's a pouch catheter. So it's sort of slightly ingrained. Stages of surgery are 1, 2, and 3 stages. With now Mr. George is retired in Oxford, he retired in February. Miss Baker and Mr. Bignell are mostly doing sort of 2, sometimes 3-stage pouches, but generally recently mostly 2-stage pouches. So that's been a little bit of a learning curve for ourselves as well as yourselves, and particularly with the 1 and 2 stage, because you haven't got that defunctioning colostomy, ileostomy even, you've got to be careful that you don't, it's almost the same principle as the cock pouch. You don't want to overstretch the pouch initially because you're allowing that and those anastomoses to heal. So that's the bit that we really have to be careful with. And you have with defunctional ileostomy with your 3-stage pouch until the stoma is closed at the 3rd stage. It's definitely a new learning curve. So once you've been through all the different stages, whether that's 1, 2, or 3, and you've got that new functioning pouch, that's not where the story ends. It's definitely where the next chapter begins, so to speak. And that's where, as it says on there, it's that new learning curve of learning and establishing your pouch functional routine. So it's a bit of a busy slide, but I was trying to condense it into not too many different slides. So again, from an ileoanal pouch function point of view, it's that initial training as the pouch starts working. As I say, it's the end of one journey and it's the beginning of a new journey, a new chapter. And it's a different bowel function. It will never be normal. Whatever anybody says to you, once you've had your colon removed, you've got an ileostomy, you've got a pouch, you're never going to have normal bowel function because you haven't got intact GI tract. And I mean that in the nicest possible way. So it's that psychological, emotional adjustment as well as the physical side of going through surgery. And it's getting to know your pouch. As Richard said, every single pouch is different. Everybody's experience, I'm sure if we would go around the room today, everybody will have a different aspect of how their pouch works, how it affects your life and things, and your journey will all have been slightly different. And that's not to say that any one journey and experience is good, bad, different. Everybody's experience is going to be individual to you. And it's learning how the pouch is working, and it's training your pouch as well. Again, everybody's pouch function is going to be slightly different. And it's giving yourself time to get to know you, your body, and to adjust to the care of your pouch. So it's not a quick thing. It's a transition. It will take weeks, it'll take months for the pouch to settle down, and you to learn how your function affects you, or how you can affect your function. Initially after surgery, the stool will be much more watery, looser consistency, because the first few days you're not going to be eating, bowel's being handled. Even if you had your ileostomy closed, then bowel function is all going to be a bit disruptive for a few days, still going to be looser to start with, and you're likely to be much more windy to start with, again, because bowel functions will be disrupted because of surgery. It's being handled by Mr. Lovegrove and his colleagues. Sensation control, that's one thing lots and lots of people worry about. Not everybody worries about, am I going to have sensation? Am I going to control pouch function? Yes, you will to both of those. You will have sensation, you will have control. Initially, that is harder to do because the stool is looser. As the bowel settles and stool becomes that little bit thicker, then sensation and control becomes easier. Okay. Correct position on the toilet is fairly essential. So it's sitting upright, fairly upright, not bolt upright, but fairly upright. Important to relax. If you're tense and stressing yourself, then that will tense all your muscles, including your anal sphincter muscles and your pelvic floor muscles, and then it makes evacuating the pouch much more difficult. So it's relax. It's engaging the correct muscles as well. So it's not just your pelvic floor, anal sphincter muscles that you're squeezing. It's using the oblique muscles. So it's the ones on the lower part of your abdomen here. So after surgery, we always talk to this with our patients in Oxford, but don't get them to do it. But the way to feel for it is to give yourself a cough and push on the lower side of your abdomen here. Don't do it immediately after surgery though, because it hurts, because obviously you're sore. But that's when we often talk about it. But if you're not sure, it's those ones. And what you're trying to do is, by squeezing those muscles, you're squeezing from the top of the pouch down. One of the problems that lots of people experience is incomplete emptying of the pouch, and by that I mean you're emptying your pouch, get up from the toilet because you feel as though you're done. Within a few minutes, you're back in the toilet, going to the toilet again, and that's probably because you've not fully emptied the pouch. And so that could be you slightly tense on the toilet and then things, but could be position. But by using your oblique muscles, you're then pushing from the top of the pouch rather than from mid or lower part of the pouch. My analogy, it's a bit of an odd one, but go with me. For those of you who remember the Generation Game years and years and years ago, if you remember the cake decorating, baking ones, cooking ones, where you've got the chef icing his cake and things, and he's squeezing the icing bag from the top, and then he empties the icing bag properly and fully. You get the contestants do it, and they're squeezing part way down, and from the bottom they leave blobs of icing and cream on their cake and thing, and most of the icing is stuck at the top of the bag. So that's the analogy. So it's a bit of an old one, but it's the best one I've got, but it works. So you're trying to squeeze from the top of the icing bag. So if you think that's the top of your pouch, so if you squeeze all the way down, you'll empty your pouch properly and fully, hopefully. As I say, with a 1 and 2 stage pouch, we very much advocate now for the first 4 to 6 weeks is to regularly empty your pouch. So you're going every 2 hours during the day, not say during the night, but during the day, which I know is a little bit disruptive, but what you don't want to do is overstretch that pouch and put strain on those anastomoses. So it's just for the first few weeks. So that's short-term inconvenience, I suppose, for the long-term gain. From an emptying of the pouch point of view, there's essentially 2 methods, sort of a regular versus a random. And what I mean by that is regular is what we tend to advocate in Oxford is go and sit on the toilet. So once the pouch starts working, which is usually within about 24 hours or so of surgery, if at 3rd stage stone's been closed, if it's a 1 or 2 stage, then because you've got the pouch catheter in your bottom, up your bottom into your pouch, as Miss Lugo said, that will be in for a few days. That will be draining, and the nurses will be flushing it on a regular basis. Once that's out, then it's starting to go to the toilet every 2 hours if you can. Some people can't hang on that long, so we suggest going every hour during the day, not necessarily at night. And then once you've got that initial pattern going, you can last for 2 hours, then slowly elongating the time frame. So add in 20 minutes, 15 minutes, half an hour, whatever you can manage to do. And then over a period of days and weeks, you'll slowly build up the time frame by adding on short periods of time each 24, 48 hours. So then you can gradually build it up to a longer time frames between needing to empty your pouch. The random approach is essentially reacting to the sensation to have your pouch open. So if you get that sensation, have your pouch open, you go to the toilet, that might be 2 or 3 hours, that might be after half an hour, that might be 5 or 6 hours. So it's very much more sporadic, random, as I say. Eventually, both methods tend to settle down to the same outcome. So it doesn't really matter which way you go. I think if it was me, I don't have a pouch, but I think if it was me, I always, when I'm talking to my patients preoperatively, I always use the word control. I'm not quite sure why, but it's the best word I can think of, as to I'd feel as I've got more control over what's happening rather than a random approach. But there's no right or wrong, it's what works for you. Okay. If there's problems, you're emptying your pouch and you're having difficulties and things, then it can be sort of problem solving suggestions of checking your posture, so how you're sitting on the toilet. You can raise your feet off the floor. Years ago, we talked about putting telephone directories, 2 or 3 telephone directories on the floor in front of the toilet to raise your feet up. Can't do that now because they're non-existent, although about that thin. I know Carol talks about the squatty potty, but I've got to remember to mention that, Carol. So that's a device you can get, which is goes around the base of the toilet, and it's essentially like a little footstool, and it just raises your feet up. So essentially, it's the angle you're sat on the toilet. So rather than being sat in a very sort of angular position, you're raising your feet up, which just changes the angle of your pelvis. It's almost your squatting position, and for some people that can help them emptying the pouch more effectively. Allow time. Try not to rush. If you're trying to rush to go to the toilet, for some people that way you won't empty your pouch effectively. So allow some time. There, we talked about the oblique muscles, and pelvic tilt is one thing that can help, and that's essentially not say how you're sitting on the toilet from a whole body position, it's more what you're doing with your pelvis. And so the pelvic tilt is essentially the rocking of your pelvis slightly backwards or forwards. So it's not a big movement, it's very subtle, backwards or forwards. And for what that does, if you think about it, when you see the gastroenterologist or the surgeons in clinic and examine you, finger up your bottom, I'm sure you all remember having that done on multiple occasions. You're always on your left side with your legs up. So you're trying to replicate that position. So by tilting the pelvis, sometimes by rocking slightly forward or slightly backwards, you're just angling the pouch slightly differently. And again, for some people, that can just help from an alignment and emptying the pouch that bit more easily and more effectively. Okay. Some people need to use a Medina catheter. So if you've got anal stenosis, pouch anal stenosis, or pouch emptying really is difficult, you can use a Medina catheter. There are other catheters available. And essentially what you do is some lubricating gel, some openings in the eyelets, openings at the end and the tip of the catheter. Essentially what you do is put some lubricating gel on the end. Optilube or KY gel, anything really, and then you slowly insert the catheter up the anal canal into your pouch. Don't worry, you don't need to put the whole lot in. Just go in. So your anal canal is about 2-3 centimeters long. So you're just going in a short distance, just at the tip and the eyelets go into the pouch, and then stool will drain out. If your stool is very, very thick, it may not drain quite so easily. So what we Also advise, if that's the situation, what we advise, use of a catheter tip syringe, and you can insert just some warm tap water into the catheter, insert that into your pouch. That will loosen the stool, and then it'll make the stool easier to drain out. When you're taking the catheter out, rather than just pulling, because the eyelets will have attached onto some of the bowel mucosa. So what we always advise is a slight twisting motion. If that still doesn't work, just insert about 20-30 mils of water down the catheter just to flush the tip, and then slowly withdraw it. Okay. There's not that many people use a Medina catheter, but some people do. Skincare, perianal skincare is vital, particularly post-operatively when you're going more regularly. Most people initially after surgery, pouch is starting to work, emptying the pouch about 8 to 10 times a day, some people a bit more. And you've got that looser, more corrosive stool. So skincare is vital. So it's just normal washing, make sure the skin is clean and dry. Some people like to use barrier creams, barrier wipes initially as well, so we advocate that, putting a small amount of cream on the skin to each bowel movement just to protect the skin. The principle of a baby's bottom is what I normally advise as an analogy. We often get asked the question, which is the best barrier cream? There isn't a best one. The best one actually is the one that works for you. Everybody will have different opinions. Lots of people use Sudocrem. I know one gentleman who absolutely loathes Sudocrem, and he tried it. He said it was awful stuff, and he uses something different. Everybody will have a different opinion. Another gentleman I can think of, he uses Vaseline, something quite simple. Lots of the baby barrier creams work, so it's finding the one that works for you. As time goes by, some people will continue to regularly use a bit of barrier cream each time. Some people use it as and when they need to. Other people never use a barrier cream. Ultimately, it's what works for you, what your pouch function is doing, and what your skincare is doing. Okay. Leakage. Some people will experience leakage, particularly at night time. So when you're more deeply asleep, anal sphincter muscles relax, particularly if you've been out and about, or you've been eating something differently, and then you're more tired. So it just takes that bit longer for the brain to react to the stimulus. So some people find they get a little bit of leakage or seepage overnight. If that's the case, then sometimes it can be helpful to set an alarm clock for the middle of the night to wake you up. So you're being a bit proactive of rather than waking up and find you've had some seepage, you set an alarm clock to wake you up, so you can react, go to the toilet before you get to the leakage situation. So K-pouch. Again, there's lots of literature there. Ileostomy Association have, and Van Woodhouse and Alison Corshaw and Carroll wrote the book on K-pouches as well, from which was published, written in Oxford as well. So post-operative care, as Richard said, it's a slightly longer admission. General post-op care is the same as any major abdominal surgery from the nurse's point of view. So you've got the stoma at the skin surface, so that has to be observed closely for blood supply. It can be very difficult to see the stoma because it's slightly occluded, obstructed by the catheter and the fixation device. And you can see two of my colleagues, Fran and Joe, slightly older picture, but it still works. Sort of, is that the is it the red button for the pointer? It is. So you can see Fran and Joe peering over patient's tummy, looking with the pen torch, just checking the integrity of the stoma. The pouch catheter, so again, it's a Medina catheter that goes down the stoma into the K-pouch, as Richard was saying, to allow that continuous drainage. You don't want to overstretch the pouch, the K-pouch. You need all that anastomosis to heal. And the nurses flush it sort of 3 or 4 times a day with sort of 20-30 mils of sterile saline or water. Again, if it's not working, it's not draining, it needs to be flushed just to make sure it's not got blocked. And the main thing is make sure nobody pulls it out. you'll have a very upset surgeon if you do if one of the nurses or somebody pulls it out, or if it falls out, it shouldn't, but if it comes out, it is, I would say, an emergency situation, a very urgent situation, because that catheter needs to go back down. Um, yeah. So over the years, when Professor Mortensen first started doing cock pouches again in Oxford many years ago, it was a case of how do we hold the catheter in place? So he initially used a galley pot, which is like a little plastic dish, which is quite rigid, which is quite uncomfortable on your abdomen. And then we came up with the idea of a baby's bottle teat, cut the end off so the catheter comes out through the top of the teat. We thought we've got to be able to do better than that. And then we found the Hollister fixation device, which is now what we use, although we haven't done a pouch, K-pouch for a few years now. But this is what we found work. And so it's a sticky pad that sits on the patient's skin. You have to just cut the hole a bit bigger. That sits on the skin. And then, so the catheter comes through the hole. Probably won't get it through because the hole's not big enough, but it will. So catheter goes through down into the abdomen, and then the tie, a bit like a cable tie, comes round and goes back into the device and holds it in. And so that's where it can be quite difficult to be able to see through underneath to visualize the stoma underneath. And then every few days or so, once or twice, a couple of times a week, the whole lot gets doesn't, but we can take off the tube, the fixation device, clean the skin and round the stoma, and then put a new one back on again. Okay. You can put a stoma bag over the top as well, obviously to collect the effluent. If you don't have it on continuous drainage, you can put a stoma bag there. If we do that, we use a two-piece bagging system, so you can unclip the outer bag to access the stoma for flushing, and then clip the bag back on again. So yeah, make sure that the catheter is well fixed and not dislodged, and particularly making sure that the fissure is aware that when you're getting up and about and they're walking around the ward from a mobility point of view, they remember to take drainage bags, catheter tubes, and they don't inadvertently dislodge the catheter. Otherwise, again, you'll have a very upset surgeon. Checking the tubing, make sure it's draining, it's not blocked. Catheter will be in for a few weeks, and then it come back, as Richard was saying, to meet us and the surgeons, and take the catheter out, and then usually in for the whole day, take the catheter out, and teach you how to re-intubate it and flush. So before discharge, sorry, I should say, it's making sure we're teaching you as an individual how to flush the catheter, so you're making sure it is draining properly. Contact details, so if there's any problems, then you've got someone you can contact, and it's establishing that care routine. So you've got to be able to flush the catheter and attach the catheter bag. Once the usually advise a medical alert bracelet as well. So obviously you've got, I was going to say, abnormal bowels continuity. You've got different bowel continuity, and so it's that. So it's, if you have a medical episode and you need somebody to be examining you doing something, somebody needs to know what they're doing to manage the pouch. See if I get it the right way, wrong way. Am I pushing the wrong button? I must be. There we go. So there you go. That's the tube fixation device in a bit more detail. So you can see how you put the tab around, create a loop, catheter goes through, and then it holds it in place. The other thing I was going to say was, when you come back to learn how to do the catheter, then it's, say you're in with us for the whole day, it's learning how to take the catheter out, re-intubate it, and being able to flush it, and if you're not able to do that, then you can't. But that's the important bit. And if there's problems, it's having contact details to contact somebody. Yeah. Okay. Oh, wait. I think that's it. Yep. Okay.
Thank you, Simon. It was brilliant. You're the expert. And does anybody have any questions at this point for Simon? Yeah.
I've just got one question. My apologies if this is a little ignorant. You were talking about evacuation of when you're trying to go and pelvic tilt and things like that. Does it make any difference depending on the type of pouch you have? Because obviously, like there's the S pouch, the W pouch. Does actually going to the toilet vary depending on the pouch you have? I'm sorry if that's a stupid question. I'm sorry.
Yeah, okay. It isn't a stupid question. So historically, it was S, W, and more commonly now it's I think most surgeons do J pouches, Richard. Yeah. And so J pouch tends to be much easier to empty because it's just 2 loops, where the S and Ws are 3 and 4. So yeah, a W pouch particularly can be quite difficult to empty because you've got the bigger pouch there. So that's where the techniques for emptying can be much more useful. Yeah,
because I have a W pouch, and that was particularly why I was asking if there was anything different to obviously the things that you've put on there that I would need to be doing differently to try and go.
Not necessarily. Okay. If you're struggling, it's perhaps working through some of those techniques if anybody's struggling, it's working through some of those techniques to see if any of those can, or a combination of them, can help optimize with the emptying. Yeah. But the bigger the pouch, it can sometimes be more difficult because it's a bit more, I want to use the word floppy for want of a better technical term. Yeah.
Thank you.
Sounds like you need to think about the icing bag. Anybody else like to ask Simon?
Alison wants to ask a question.
Just when you are looking at the catheter for the cock pouch, do you measure and mark the catheter as to how far in it should be?
Yes.
Because if it goes too far, it can puncture, and not far enough, it won't drain properly.
Absolutely. So that's marked at surgery. So once the catheter's been put in surgery, and you've got the length that the surgeon's intubated in surgery, at the exit point at skin surface, if the surgeons haven't marked it, we'll mark it. So we then know how long, how deep it has been in, so we can replicate that. Yes, absolutely.
And then you replicate that for patients for going.
Yes, yeah, absolutely. Yeah.
Thanks, Alison. I know you've got lots of experience with cock pouches. So, Simon, do you have many cock pouches coming back to see you now?
We've got a few. I haven't done one since before COVID. Mr. George was the last one to do one.
And he's now retired.
He retired in February, yes. Very sadly. And so yeah, there's a few people. There aren't that many people that are. They seem to be working well. There's one lady from out of area who's been having stenosis issues with the stoma, and that's causing her most of the problem trying to get a catheter that's small enough to go in. Yeah.
And I guess you mentioned the medic alert bracelet. I think it's really important that patients carry information with them.
Absolutely.
If they're admitted to hospital, people need to know what's going on.
Yeah.
And maybe if you're going on holiday, you need that in various languages.
Yeah. Yes, yeah. And even with having an ileorenal pouch, is it worth having some sort of medical alert or or carrying some sort of card to say you've got altered bowel anatomy, so that if you're away somewhere, somebody doesn't know what a pouch, either this country or abroad, somebody doesn't know what a pouch is. You've obviously got some. Then at least you can wave that at the doctors who examine you, so that at least they've got a bit of an idea of what a pouch is.
Simon, you're going to be with us for the
Yeah,
day,
I'm here all
so
day, yeah.
we can talk to Simon again
Yeah.
at our leisure. So thank you very much, Simon.
Thank you.